Everyone, we are going to start our review for the midterm 2020 Pharmacology 1, and we are going to start we have 4 lectures for this midterm. The first part is going to be the pharmacological principles, and for that, I'm going to remark a few things. All right, so talking about pharmacology principles, by the way, at the end of the webinar, I'm going to make a summary of all what we want you to know, or we want you to keep always in your mind. Okay, so pharmacological or pharmacology principles. So the first thing that we need to know is about the pharmacology is the study of the drugs, and this pharmacology is composed by different components, right? The two major components for these are going to be the pharmacokinetics and pharmacodynamics. Okay, so the pharmacokinetics are going, first of all, what is drug? Drug is any chemical that affect the physiological process in living organism. So what does it mean? That any drug or any medication that you're going to take, none of them are going to create a new function at all. I'm recording or not? Yes. They are not going to create any new function. So we already was talking, for example, about the antacids, and we are talking about PPI and anti-H2, for example. And those drugs, what they are doing is to inhibit the production of something, right? So it's going to decrease the function of something. In this case, the production of gastric acid, right? For example, if you have problems with the thyroid gland is you need to take two hormones at T3 and T4. If you have hypothyroidism, that means that you have a low functioning of your thyroid gland. So what you're going to do is to give what you need, T3 and T4. Parkinson, you have low in dopamine. What you're going to try to do is to increase the dopamine. So what they are doing is not creating a new function. What they are going to do is to increase or to stop or to block one of the functions of the body. Some functions of the body are going to be increased, so medications are going to lower. Some functions of the body are low, so we give medications to stimulate that function. So that is actually what is pharmacology. Okay, so there is no magic drugs and any magic substance. Okay, so all right, so let's keep going. Talking about the chemical name, generic name, and trademark, trade name or proprietary name, please, you need to remember that here the chemical name is not going to be used. What you need to remember is the generic name and the trade name. So that how they write it down is. So generic name, for example, ibuprofen, lowercase, generic name, lowercase, ibuprofen, and trademark is going to be capital letter. Okay. Now I want to ask you, and this is one English question, not necessary for this, but probably for the future final exam or your English or HESI, is what is better? So the medications that are having in the stand as generic name, or the ones who appear with the trade name or the commercial name? Which is better, for example? What do you would like?
Generic.
Generic is cheaper, right?
Generic. Yes,
right?
And also you can differentiate easier.
Yes, and trade is going to be more expensive, correct? Okay, so you just remind me 2 things that I need to tell you. 3, well, 2 is okay. Generic is not as good as a trademark or commercial name. Okay, why is that? Because the FDA, Food Drug Administration, are going to allow the commercialization of this generic name without having too many studies. Meantime, the pharmaceutical company who is investing in a lot of investigation to make a better pharmacokinetics, a better pharmacodynamic, spend more money and more time to find out the combination appropriate for to make more effective that drug. You okay with that? Okay. So if you that is cheaper, yes, but why is cheaper? Nothing is free. Okay, it's cheaper because somebody wants to give us to be nice with us. Not at all. So cheaper because they cannot ask for more money because they are actually didn't do as many studies at the commercial name. Is that clear? Is okay with that? We okay with that?
Yes.
Then number two, somebody was mentioned something that I skip on in my head about the trademark and generic name. Okay, so I will remember. Okay, let's start. Let's continue. So don't forget the capital letter and the lowercase, please. So here we have some names. We have, for example, the generic name. We have the aspirin, that is Ecotrin. So everything is in lowercase on the left side of the column, and everything is capital letter on the right side. Okay, so please, I want you to start getting familiar with the names. Okay, with the name. These names are very common that you're going to see every single exam in your future. All right, so naming the pharmacos. So this table is useful in order to do your flashcards that I'm not going to explain because that we already talk in class. Flashcards. Okay, so you can classify in different modalities as you like, as you can rememorize better. Okay. All right, so here we have the pharmacokinetics and the pharmacodynamics. So everybody knows that the pharmacokinetics is how the body affects the drug, correct? How the body affects the drug. How the body affects the drug. How the intestine is going to absorb the drug. Body, intestine, for example. What you're talking about is the absorption. This is the drug. For example, the stomach, gastric acid, how is going to affect the drug, okay? If the gastric is too low, it's not going to dissolve the drug, so there is no absorption. So how the body is going to, is a factor in order to change the activity of the medication. All right, so for example, how the body is going to affect the drug. For example, you have liver failure. Liver failure is not going to metabolize the drug. So the drug is going to start having more side effects. That is the pharmacodynamics. Okay, so pharmacokinetics and pharmacodynamics are going to be hand by hand. They are not completely apart. So they are working together. Okay, one thing here, new drugs are related to have better pharmacokinetics and better pharmacodynamics. Pharmacodynamics is going to be how the drug, and remember the D, how the drug is going to affect the body. For example, that is talking about the side effects, right? The pharmacokinetics is going to study how much dose are you going to give to the patient, okay? For example, first generation of some drug, you give 100 milligrams of the dose to make effect. The second generation of that drug is going to have, let's put it, the same effect with 50 milligrams, half of the previous one, and with less side effects. What else you want? To last longer in your body, right? So that is actually the pharmacodynamics in relation to the pharmacokinetics. All right, so the pharmacokinetics is going to be the ADME, as we already talked in the past. ADME is the absorption, distribution, metabolism, and the excretion, right? So those are actually the 4 components of the pharmacokinetics. Absorption in the intestine, distribution in the vascular system, in the vascularity, and the levels of proteins. So you must nail it now. Vascularization and proteins. Metabolism is the liver. Excretion basically is the kidney. Again, absorption is the intestine, correct? Metabolism is going to be the liver. Excretion is going to be the kidney. I'm going to stop here in the distribution because probably it's not that clear yet. Distribution is how the drug is going to get distributed in all your body. When you take a medication PO, they're going to go to the intestine, it's going to be absorbed, and the absorption then they go to the circulatory system. Okay? The circulatory system. In the circulatory system, that is the vascularization. Vascularization is the amount of vessels, the amount of blood flow that is receiving or give blood supply to the organ. They are going to be proteins. Where? In the circulation. Proteins, 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 proteins. Proteins are going to actually be the taxi drivers. The taxi drivers for everything. Taxi drivers. Okay. So it's going to be taxi driver for macronutrients, for micronutrients, for drugs. All these are going to be transported by a taxi driver. Specifically, it's called the albumin. By the way, who produced albumin? Is the liver. It's all news, right? So this is something like what is your first and last name? So, and the albumin, so when this low is going to have actually is going to have when it's low, there is not too many transporters of the drug that can go all over your body. Example of that. So for example, a malnourished are going to be low in proteins, yes or no? Correct? A very well nourished is going to have high levels of proteins. They have the same disease again. Who is going to heal first? The one who is going to have better nutrition with low levels of proteins. Okay, we got it? Now, these transporters are very, very important. If you are malnourished, you have low levels of proteins. Low levels of proteins. So, and what are doing the proteins with the drug? The proteins with the drug are going to be, hello, a taxi, I need a taxi. The drug is climbing on the protein, and the protein and the drug, they are going to travel through the circulatory system. There is a moment I said the drug, okay, I stop, please. I go into just arrive to my, I arrive to my, the place I want to go. So then the protein release the drug, and the drug is going to enter into the cell. So the drug that is going to get into the cell or inside the cell is what we call the free drug. Free drug. So the free drug means that it's not attached to the protein. Okay? But this drug and the protein are going to play a game that is a yo-yo game. The yo-yo game. Yo-yo game means that, well, it's not in the books, it's just the way I see it. The yo-yo game is that the proteins are going to be going and back with the protein. So we have a protein, we have a drug, and the drug is coming and then go, coming and go, coming and go. Attach and free, attach and free, attach and free. You got it? Now, what is the importance about this? If you are malnourished, there is a little bit of proteins, and if you give the full dose of drug, there is no transporter. So basically, everything is going to be in the free drug, correct? And this free drug has more options to enter into the cell. So that is going to lead into toxic levels. So if you have a malnourished and you want to give full dose of the medication, you can kill the patient. Okay, so we need to know and we need to assess the nourishment level of the patient. The opposite, if you have a lot of proteins, and the drug is coming, PO, you're taking the drug, or IV if you want, any route. If you have too much proteins in blood, what happened? The drug most likely is going to be mostly of the time attached to the proteins, yes or no? Right? If that is happening, the drug is going to last longer in your body. So if there is more affinity to proteins, the dose of the drug need to go down, because this drug is going to stay longer in your body, and we can use that property as a benefit for the patient. So in conclusion, the ADME is the absorption, the level of the intestine, distribution, that is the vessels, the vascularization, and the levels of proteins. Metabolism is the liver. Talking about the metabolism, if you don't have any questions about distribution, I hope that is clear. If not, just let me know. And this, the metabolism is going to be related to the liver. Okay, the liver, when the liver is failing, so what you need to remember is this. For example, you have this drug, a pill, take the pill. Do you think this pill is the one who is making effect? No. So you have actually a factory that is the liver. Is the liver. The drug is coming to the factory, and the factory is going to transform the ingredient into active ingredient. Okay, so it's the liver, the one who is going to transform based on the studies of the pharmaceutical studies, whatever. They know that the liver, it need to have a very important role in order to make the medication be effective. For example, we have the benzodiazepines, the benzodiazepine. Benzodiazepine, we have, for example, diazepam, that is very common. And this diazepam, the pill that you have in your fingers, is not doing anything. The pill is not going to do anything until it's being processed by the liver. And the liver is going to transform this in metabolites, active metabolites. Just for us, are going to call just the active ingredient. Okay. So liver is a very important thing here. So if you see, the majority of the medications are going to be transformed, are going to be processed by the liver. Is that clear? All right. And then we are going to do a small conclusion, and please, you can participate. Then we have the excretion, right? Excretion. What is excretion? Excretion is basically by which organ?
The kidneys.
Kidneys. So that's why the doctor, when they give a medication, take a lot of water, right? Take water, yes or no? Why? Because why you need to take more water? Because the kidney is going to excrete, so look at this. If you have a material here, a raw material, to produce something like let's put it a wood here, or some lumber, and you're going to produce a chair, you have a chair, okay? But when from this raw material to have a chair, there is a lot of debris, right? It's going to get rid of, correct? Right? So not all the material of the wood or the lumber are going to be used for the chair. So because we need to get rid of some part of that. So the same thing is doing the drug, the body with the drug. The drug that is being taken is going to be metabolized, processed by the liver, and there is actually the active ingredient. That is the one we are going to use. But there is other ingredients that are not going to be used, because it's part of the process of the activation of this medication. So this is what need to be excreted, and that is going to be done by the kidney. Now, if the kidney is not working, what happened with the waste products? Are going to, come on, tell me, are going to accumulate. Start to talk. I'm going to start asking. Please participate. Don't let me alone here, because I'm going to fall asleep. Okay. All right. So it's going to accumulate. So that's why you're going to take much more fluid in order to wash out and in order to flush it, all these waste product in more faster manner. So in conclusion, you are going to have two main organs that are going to be part of this pharmacokinetics. These are the liver and the kidneys. Now, can you understand from the previous classes why many medications are going to, we need to be careful with hepatotoxicity?
Yes.
Right?
Yes.
We understand now why we pay attention in the nephrotoxicity. What
Yes.
is hepatotoxicity? What is nephrotoxicity? Hepatotoxicity, what is happening is how you check the hepatotoxicity with lab test, or no lab test. We didn't invent the lab test to check if there is hepatotoxicity. What is the lab test for hepatotoxicity? To check the
AST, ALT.
LFTs. And for the kidney, we are going to use the Chem 7. Correct? Okay, so that is what is hepatotoxicity. So why these LFTs are elevated? Why the BUN, the creatinine are going to be elevated? Why? First of all, LFT is liver function test. So these are measuring some enzymes that are inside, I said inside the liver cell. If you destroy the liver cell, what happens with those enzymes? Are going out. Where? To the blood. And that's why the elevation of those enzymes can indicate that you have destruction of the liver, hepatotoxicity. Is that clear? The BUN is the blood urea nitrogen. You know, by your course of bioscience and anatomy physiology, we have the metabolism of the proteins are going to end into ammonia, correct? And the ammonia is taken by the liver, and the liver is turning the ammonia that is very toxic, very bad guy, into urea, correct? And the urea, where is going to be eliminated? By the kidney. Now, if the kidney is not working, do you think the urea is going to go out? It's going to stay, and it's going to accumulate in blood. Make sense? So that's why BUN is going to be elevated. So elevation of these elements enzymes are going to produce this problem. So we need to always think about, when you are talking pharmacology, into your hepatotoxicity and nephrotoxicity. Okay, so especially when we are remarking more than one time in many times in one of these drugs. But what is toxic? What is really what is this? What happened? Oh, okay. So what is toxicity? Toxicity could be hepato, could be nephrotoxicity. So hepatotoxicity is going to be, this is the vessel, normal vessel with a blood flow, okay? And the toxins, these elements that are waste products, or the drug itself that is not very well metabolized, are going to be accumulated in the bloodstream. This bloodstream accumulation of these toxins are going to go into the vessels of the liver or the kidney. And what happens with these vessels? Are going to produce an intense vasoconstriction. So the less blood, less oxygen, and the tissue start to die. The cells are going to start opening and dying and release the enzymes. Okay? And the kidneys are going to affect the nephrons. The nephrons, that is the functional unit of the kidney, that are going to be eliminating, remember, fresh, right? Filtration, reabsorption, excretion, secretion, and hormones. And actually, excretion is the one who is going to be affected. And that is going to be actually your overall about hepatotoxicity and nephrotoxicity. So I give you even a little bit more than in the lecture. So let's keep going. All right, so that is the summary. You got it? All right, so let's start. Okay, so that's again, so we already talked about that. All right, so we need to talk about the bioavailability. The bioavailability. The bioavailability is how much of the drug is going to go into the bloodstream. So for example, you have a medication, a tablet that is going to be into the stomach. That is going to be 100%. In the stomach is going to be the acid, correct? This acid is going to, let's make some example. It's different number for different drug. So this is 100% that is available. In the stomach is destroyed, let's put it 20%, and only available is going to be 80. Continue the race. They go to the intestines. In the intestines. So let's put it that 10% are lost. So you have now, instead to 100, instead to 80, you have 70%. So the rest is going to be to the fecal material, etc. Then they go to the liver. In the liver is going to be processed. It's the big factory that is as a raw material in order to produce some useful instrument, right? In this case, for example, instead to have 100, go down to 80, go down to 70%. Let's put it, they go to 60%. So from this, and then they're going to go to the bloodstream to make action. So that means that this drug, only from the 100%, only 60% are going to be effective. And that is already known by the pharmaceutical industries. So that's why they give you this a dose that is according to the studies that they were making. So that doesn't mean, okay, so the liver is going to be only 60%, so why I need to take 100%? No, because if you take your 60%, that will be your 100%, new 100%, will be decrease, and the dose is not going to be effective. Okay, so it's not that simple. So that is the bioavailability. The first pass effect, the first pass effect is everything that is going to go to the GI tract. I don't need to know, I don't need to ask what is the GI tract already, right? Okay, the GI tract, and the GI tract is going to be all from the mouth to the esophagus, the stomach to the duodenum, intestine, and they're going to be absorbed. And then they're going to go where? To the liver. And all this is the first pass effect. All this is the first pass effect. So the first pass effect is going to affect what? The bioavailability. Okay? All right, so listen again. The first pass effect is going to be all this route where you have 100%. At the end, you will have 60% that is going to the bloodstream. That 60% is the bioavailability. So the bioavailability depends on whom? On whom? On what?
On the patient.
First pass effect. In the first pass effect, thank you for participating. First pass effect. So the first pass effect is going to have a very intense effect on the bioavailability. Is that clear or no?
Yes.
Yes, Dr.
Yes.
Okay. All right, so this bioavailability is going to change. For example, depends of the what?
The
This is
route.
not a lecture, huh? Who said that?
The route is
Who
Mark.
said that?
It's Mark.
Mark what?
Come on,
Mark,
Dr. G. Austria.
Mark Austria. Thank you, Mark. Thank you so much. Route. Excellent. Excellent, Mark. Route. Okay. So for example, it's not the same to have PO than IV, correct? right? The PO is going to be affected basically by the first pass effect. But the IB is going to be affected by the first pass effect, yes or no?
No.
Yeah, no, no.
No, yes. No, no, because if you both go to the vein, they're not going to go to the
Going
stomach.
directly to
Go
the
directly to the
bloodstream.
bloodstream, right? You got it? So that's why the depends on the route. In this case, for example, the dose of the PO is, let's put it like 100 milligrams, but the IB in solution is going to be like 20 milligrams. Why? Right? Because there is no first pass effect here. It's to go directly to the bloodstream. Is that clear? Okay.
Yes.
Yes.
So everything that is going to touch the GI tract is going to suffer from the first pass effect. You got it? Okay, so absorption, so the first pass effect, the pre-systemic, that is an old name, but it's still mentioning. So it's first pass effect. Okay, so what is a prodrug? A prodrug is any drug that are going to be inactive as PO, inactive, but is going to be activated by the liver. So a prodrug. So prodrug is not a drug yet. It's a pro. So it's before is a little bit before to be a drug, right? Effective. So the drug is going to be really elaborated and ready to and active after they pass through the liver. Okay. All right. So bioequivalence. The bioequivalence is actually when two different drugs are absorbed in the same amount, in other words, have the same bioavailability. So two different drugs, A and B drug, okay, so they are going to be absorbed in the same amount. That doesn't mean that these drugs are the same or similar, or I mean, similar drugs. It could be totally different drugs, but the amount that is being absorbed, if this is equal for both drugs, that is called the bioequivalence. Bioequivalence. Let's see. For example, aspirin. Aspirin is equivalent as 1, and less for pain, and ibuprofen is equivalent to 3. Okay, so that means that in order to have the same effect, you have three times more aspirin than 1 ibuprofen for pain. Aspirin is good for many reasons, right? But there is equivalence, right? And in this case, there is no bioequivalence because there are different amount. But if they are going to be absorbed in the same amount, that means that they have, that is called the bioequivalence. So that is about that. Okay, so chelation here. Chelation is you have here the drug here. This is chelated. What is a chelation? Is this, all this white. So if you have the drug and you have calcium, for example, calcium, this calcium is coming from the milk. One example is the tetracycline. Tetracycline are going to be, tetracycline is going to be chelated by calcium. So it's not, you cannot take tetracycline with milk. Why? Because if this drug is small, they can be absorbed. But if this is chelated, the drug is actually associated, making a bigger structure, and that cannot be absorbed. We got it? So you need to be careful with that, okay? Especially, we have, oh, there you are, tetracycline. Quinolone, that is a fluoroquinolone, is a antibiotic, very potent. The digoxin for arrhythmias, for heart failure. Okay, so for example, they can actually not take it with iron. Iron produces chelation. Calcium produces chelation. Magnesium produces chelation. Okay, you already talked about magnesium, right? Remember, for that is going to be an antacid, right? The Milanta, right? Don't take it with the antibiotic. Okay, milk magnesium, right? Don't take it with antibiotic. Don't take it with milk. Don't take it with products with having iron. Okay, all right. The routes are going to be enteral, parenteral, and topical. So you need to remember where is oral, sublingual, buccal. What is the buccal? Between
The
the
cheek.
Between the
yeah,
cheeks.
between the what the how you call it, the gums and
The gums and the cheek.
the cheek. Yes, who is that?
Glenda.
Oh, okay. Oh, okay. Hi, how are you? Good. Okay, rectal. Okay, rectal. Talking about rectal, that is partially. Partially is going to bypass a first pass effect. Okay, so why is that? Because the rectum is going to evacuate his blood supply into the retroperitoneal space, means into the IVC directly. Okay, so there is a cross-sectional anatomy there, but rectal it can be considered to bypass partially the first pass effect, because rectum is part of the GI tract, correct? Okay, suppositories, for example, right? The bioavailability of suppositories is better than the pills. What do you think? Who is better, the rectal route or the PO route?
Rectal.
Rectal route.
Rectal.
Right? Because they are going to bypass partially the what? The first pass effect. We got it? Okay. NG tubes. Okay. And here we have questions that are being made for your practice. Okay. Okay. So from this, probably I want to go here. So you need to know the difference between elixirs and syrups. Elixirs is high amount of alcohol, and syrups high content of sugar. Why? Because the active ingredient in the syrups are very bitter. And the elixirs are having high content of alcohol. Why? Because they actually need alcohol to be absorbed. For example, the iron. Iron need to be in elixirs. And robitussin is sweet. Why? Because the active ingredient is going to be, depend what it is, guanefacine, whatever, is going to be bitter. We got it? Now, from this, which one is having fastest absorption? PO, we are talking about PO. The fastest absorption, you can tell here, right? What they say here, fastest, right? Is the liquids. Liquids are faster than suspensions. Pepto-Bismol is suspension, for example. Milanta is a suspension, for example. Powders, faster than capsules, tablets. So look at this. So the fastest absorption are liquids. Liquids. That's what I want to remember you to remember: elixirs and syrups. Okay. Coated tablet. That is basically to prevent bitter taste. Enteric coated tablets is to prevent the acidity. So, but in general, we are going to consider these both. You don't chew it. No, chew it. Don't chew these medications. All right. So IV is the fastest. Topical route, we have the skin. You know the skin is epidermis, epidermis, and subcutaneous tissue or hypodermis. You need to look for the more thinnest area of the body in order to put the patch, and the patch will be able to be will absorb the medication. inhalation, that's sprays, for example, inhalers are going to be considered topical route. Topical route. Protein binding, we already talked about that. Other routes of excretion are going to be the GI tract in feces, the genitourinary system, the urine, and the respiration, even the skin. The skin. If you take a medication, you smell the skin, and you're going to smell that is the smell of the medication. So there is different route, but the principle and the main route to excrete the waste product is the kidney, are the kidneys. Half-life drug. So please be alert with your calculator if you want to do calculator for Friday. Half-life time, half-life of the drug or half-life time is the amount of time required for half of the drug to be eliminated from the body. So I didn't say is half of the drug that stay in the body. No, is half of the drug that is being eliminated by the body. Okay. All right. So first order, zero order. We have, for example, first order. The majority of the drugs are going to be that. So if the more you take, the more you excrete. The more you take, the more you excrete. The more you take, the more you excrete. Okay. But here, the more you take, the same is not going to eliminate it all. If you take this amount or this amount, doesn't matter. So in this case, if you take this amount, the elimination is going to be like this amount. If you take more, the elimination is going to be the same. So that is going to be having an accumulative effect that is going to reach the therapeutic level faster. And actually we have, for example, the warfarin. Warfarin is one of these. So if you take warfarin, so that's why it's very difficult. So that we have antidote for warfarin. The warfarin, if you take warfarin, a lot of those is going to be eliminated in the same amount every time. So that's why it's very dangerous. It's very dangerous. Warfarin, lithium, theophylline, heparin, aspirin, alcohol. A steady state is the intake and elimination of the drug are in equilibrium. So the same coming in, the same coming out, right? So that is actually a steady state. Peak level is when the highest blood level of reach the highest level in blood. How you pronounce that? Always trough, right? Trough, I said that,
Yes.
right? Trough level is the lowest blood level of the drug. Okay, that is going to have a therapeutic effect. Okay, so that is trough. Toxicity. Okay, please. Okay. All right, so pharmacodynamics, we were talking about that. So everything, especially what I don't want you to just get dizzy with all these names and all that. I just want you to remember the side effects, adverse effects, contraindications. Okay, just a moment. Okay, the contraindication. Okay, interactions. What is the difference between side effects and adverse effects? What is the difference between side effects and adverse effects?
Adverse or life-threatening.
Huh?
Side effects is
Adverse
you
are more
can
serious.
Exactly. Yeah, very good, everyone. Side effects are going to be what you expect, right? And why do you need to know the side effects? What for?
For precaution.
Because you need to educate the patient, right? There is
Yeah.
medication who is going to make you pee red, right? And that is a side effect. That is something that is expected, right? So the, for example, the aciclovir. What is the side effect of the aciclovir? Ointment,
Burning.
burning, right? So that is a side effect or no? Yes, right?
Yes.
So another, for example, aciclovir, we have the sidobudin. Remember the sidobudin? Sidobudin is for what?
HIV.
HIV, right? So what could be an adverse effect? It could be BMS, yes or no? BMS, what is BMS?
Bone marrow suppression.
Bone marrow suppression, right? Who else having bone marrow suppression? Ganciclovir. Okay, guys, you need to review. Okay,
The ranitidine? No?
sorry? Sorry,
Was
there.
it the ranitidine?
The betadine?
No, the
Who is this? Okay, so tell me. Okay. All right, so that is about the, so if you rephrase, I will be happy to hear again. All right, so contraindication, main therapies, palliative. Palliative means that it's going to alleviate signs and symptoms. They're not going to cure. Example, patients with cancer, right? Or hospice. Prophylactic medication is to prevent the to recur the disease or to appear the disease. Prophylactic, for example, what example in the lecture we was talking about prophylaxis? In which disease?
The anti-malarial, right?
Exactly, prophylactic, right? And this prophylactic is taken when you go to trip. How earlier?
2
Would it
weeks
be
2
before?
weeks
and 4
before
weeks after.
and 4 weeks after, up to 4
Great.
weeks. Okay, great. Empiric is based on the experience, right? Empiric, you know that you have actually, for example, the bacteria for UTI. UTI is the E. coli, correct? E. coli. So basically 90% or 95% of all these UTIs are going to be by E. coli. So that's why they don't wait and they don't wait until the culture appears and confirm the bacteria. They start giving you treatment. Meantime, the urinalysis plus the culture are running, and in 2-3 days they have the results. Basically, they confirm that it's E. coli. But if there is no E. coli, they still tell you stop the medication. They call you and change medication. Okay, empiric. Monitoring is actually the for example, you're going to monitor the patient clinically and by laboratory. Monitor the patient. Clinically means how are, if you expect your blood pressure is high, you have hypertension, what do you expect? The medication is going to lower the blood pressure, correct? If you have pain, you give medication, you expect the medication go down, okay? Now, there's other medications like the digoxin, like warfarin, like heparin, like lithium or theophylline, another one that we are going to see later. So these actually, they have a very narrow threshold. For example, if you take your medication of Tylenol, that is the paracetamol, is the acetaminophen. My God. Okay, so you can take up to 3,000 milligrams. So the therapeutic range is this wide. So you can go all this area. These are the concentration of Tylenol in blood. So you can go very low, high, but all these have some effect already for the pain, for example. But let's talk about digoxin. Digoxin is going to be 20 micrograms, and the threshold for therapeutic range is this, very tiny. So if you give 1 microgram, so 1,000th of a gram, all right, 1,000,000th of a gram, you're going to pass the threshold, and you can have or toxic levels, or actually you can have no effect at all. So that is the monitoring. So what you're going to do is to monitor the patient before and after you give medication to the patient. You need to check your baseline, right? And then after you give the medication, PO, you're going to wait until half an hour, 1 hour to make, is there some effect for pain? That is very common. Tolerance. What is tolerance? Tolerance is a term that we are going to use later on. Tolerance is a medication who is going to, you need to take more dose next time to have the same effect. For example, just to give you one example very easy, the tolerance with alcohol. If you take alcohol, you never took alcohol before, with 1 glass, you get drunk, completely drunk, right? But let's practice. Let's go for 1 week doing the same thing. Now, in the next week, you will not need 1 glass to get drunk. You will need 2 glasses to get drunk. Let's keep practicing 2 weeks. The next week, probably you will not get drunk with 2 glasses. Next time, you will need 4 glasses in order to have the same effect. Is that clear? So the tolerance is based on what the liver is doing. So why you have this tolerance? Let's make it about alcohol, because the liver, when you are, I said, training your body, means that the liver starts to produce more enzymes who are going to metabolize faster the alcohol. Okay, so that's why when you keep taking the alcohol, your liver is going to have more enzymes who are going to metabolize faster, and actually the effect of the drug is going, the effect of alcohol is going to be lower. Okay, dependence is physical and psychological dependence. We are going to see next class. We are going to have drug addiction. All right, so nothing about synergy. This is not anymore in the course. Oh, the 6 rights. Okay, how to remember the 6 rights? Remember the mnemonic? I'm alone or what? Hello?
Tramped, right?
Trump, yes.
Yeah.
Trump, no, Trump.
Trump.
Sorry, no, you're not Trump, not the president. Trump, okay. All right. The 6 rights are going to be T. What is T? Time.
Time,
R.
route,
Route.
A.
action, dose,
Amount.
Amount.
Amount. Wow.
M.
Medication.
Medication.
Right medication. Name, right? P.
The right patient.
Patient.
Right patient, right? Right documentation, right, the right to deny the treatment, right? Okay. Okay.
Dr. G,
Yes.
my mic cut out while I was trying to answer you before. I was trying to say ganciclovir.
Oh, ganciclovir.
Yeah.
Yeah. What? Yes, ganciclovir is the BMS.
Yeah.
Ganciclovir, BMS, aciclovir, ganciclovir. Those guys can produce. The sidobudin and the ganciclovir, right? Okay.
Yeah.
All right. So we already talked about all these. The 6 rights. Okay. So try to prevent. There's some questions on the exam. I'm not going to show you. And let's finish our first lecture. All right, so let's go to the second lecture. Okay, and for this, I want you to give me just 5 minutes break, okay?
Okay. Thank you, Doctor.
Okay, so let's continue our discussion about a review of the lecture number 2. We was mentioning that there is 4 main components. Pregnancy, you need to be careful with drugs that are taken during the pregnancy. Breastfeeding, that they pass into the maternal milk, and pediatric, neonatal, and elderly. Okay, so you will see in maternity, pregnancy, and breastfeeding that is very, very intense, very, very interesting. The only thing I want just you to remember a few names here, just to pregnancy. When you are pregnant, you can use heparin, can use insulin, that are the most common. Okay, insulin in case of diabetes, and heparin in order to prevent some bleeding, clot process, etc. So heparin, heparin is the only pathway is parenteral. Insulin is there is no tablets. This is that doesn't mean that parenteral always is going to work for a pregnant, and that is not not in all cases. So heparin and insulin can be used for pregnant. What you cannot use in pregnant, you cannot use in pregnancy are, number 1, the warfarin. Warfarin is anticoagulant, similar as the heparin, but warfarin is what? Is PO, PO, enteral, okay? And heparin is parenteral. Warfarin, PO, and other one that you cannot take is the oral hypoglycemic drugs. Okay? All right, so these 4 things. No warfarin, no oral hypoglycemic drugs. You can use heparin, you can use insulin. Why? Because they do not pass, these ones, heparin and insulin, do not pass the placenta barrier. In the breastfeeding, it's very common to have anti-anxiety medications. Anti-anxiety. These anti-anxiety medications, for example, we have the benzodiazepines. What happened with my pen? Benzodiazepines. Don't tell me it's broken. Yeah, okay. It's a benzodiazepine. In neonatal and elderly. So please put in your mind the pharmacokinetics and the pharmacodynamics. Neonatal, we are going to focus in the liver. Elderly, we are going to focus in the liver. There's other things that we need to focus, the stomach, etc. But the liver is the one who is the factory to metabolize the drug, correct? In the neonatal or pediatric, neonatal is up to 28 days. Pediatric is actually infant up to 1 day. Pediatric is considered until 18 years old. The liver is not totally developed, not completely developed. It's not completely developed. That is the reason. And the elderly, the liver, not because of this, is because the liver is losing function. Is degenerating, is deteriorating, is not as working as it was done. In those cases, you need to adjust the dose. Adjust the dose. Generally, in neonates, in infants, we, in general, it's not for every drug, but in general, to give you an idea, you decrease in half the dose. But not, you need to do that under prescription, of course. Okay, and the liver in the in elderly, we are going to give about 3/4 of the dose. So what I want you to remember is this. What I want to remember is that the dosage for adults are going to be different for pediatrics and different from elderly patients. Okay, we got that?
Yes.
All right, so talking about the Parkinson. I said this is not a lecture, this is a highlight of all the main topics, okay? So I'm not going to explain, oh, you want Serengeti River? You want Serengeti River? No? No Serengeti. Silence, nobody wanted. Okay. Okay, Parkinson disease is a progressive disease, right? That is basically the diminish of the dopamine. And for that, let's go to our chart that we already been talking. Okay, so there is something that I need to, oh yeah. Okay, so here you're going to see that we have different words. The pseudo-Parkinsonism. What is pseudo-Parkinsonism, please?
Parkinson-like symptoms without it being actually Parkinson's.
Exactly. Is pseudo-Parkinsonism perfect, thank you? Or Parkinsonism? Or pyramidal? Sorry, it's extrapyramidal. Extrapyramidal movements. Extrapyramidal movements, Parkinsonism, and pseudo-Parkinsonism are the same thing. It's a different name. So they look like Parkinson, but they are not Parkinson. So there are drugs that are going to produce this. For example, we was talking the metoclopramide. What is that? Metoclopramide. What is that? What medication is this? Metoclopramide. Who can tell me?
It's usually used for GERD.
As a prokinetic, right?
Yes.
Yes. And it's going to be used for nauseous, yes or no? For nauseous.
Yes.
And what is the name?
Reglan.
Reglan.
Reglan?
Yes, Reglan. Reglan. How you call Reglan? Reglan. Reglan. Okay. So this Reglan is the mechanism of action is an antidopaminergic. So that means that it's going to oppose the effect of the dopamine. And what happened in Parkinson? Low levels of dopamine. Okay. The metoclopramide is a prokinetic. Why is the metoclopramide a prokinetic? The prokinetic is because they are going to regulate the peristalsis. Is a motility regulator of the GI tract. What is doing the prokinetic? Is going to evacuate faster the chyme from the stomach to the duodenum. And what is going to happen after that? Less production of gastric acid. We got it? So metoclopramide is going to be used for many reasons. And here I'm talking about that because that can produce pseudo-Parkinsonism or extrapyramidal movement or Parkinsonism. It's the same. Is that clear? Okay. So here we have in Parkinson, you have many, we talk about a lot of Parkinson. So I'm just going to go to the drug management. And for this, you're going to use the MAO inhibitors. Number one, that is a neuroprotector. So that what is the purpose of, what is the goals of a nurse to treat the Parkinson? To delay the progress of the disease, to calm the signs and symptoms, to make the patient be able to do his own daily activities. That is the goal. And the medication is not going to make effect between 2 weeks, start to make some effect, but the full effect is about 6 weeks. 6 weeks. So patient adherence is very important. MAO inhibitor is the monoamino oxidase inhibitor, is inhibitor here, inhibitor. That is going to actually be the first line of treatment. If MAO inhibitors, that is the selegiline, so please mark this in your hand, write it down 10 times in your paper. Selegiline is always very common. Selegiline. This selegiline can lead into hypertension. When and how? Who can tell me? When and how? MAO inhibitors. Somebody? How many we are? Half, 50%. Okay, so when? What do you think? When? Miss When? Don't tell me you're staying there recording my...
Yes, Dr. G.
Okay, okay. All right, so hypertension and MAO inhibitors. What happened? Hypertension and MAO... Oh, really? Do you see that? Oh. I just got... Oh, okay, all right. That's very interesting. All right. So MAO inhibitors are going to, if you mix with what? Wine, cheese, even beer, they can lead into hypertension. Hypertension. Got it? First line. Second line, if that is not going to work, you give dopamine. Dopamine is the apomorphine apokin. If that is not going to be effective, you add the levodopa. Levodopa, carbidopa. Okay? The carbidopa, open eyes, open ears. Carbidopa is given together with the levodopa. Why? Because the carbidopa are going to be degenerated in the peripheral nervous system, leaving the pathway free to keep going to the central nervous system, the levodopa. So carbidopa is a distractor, in other words. If this is not working, you need to add COMT. Okay, entacapone. For this, I'm going to go very fast to some side effects that I want to just go with you. Okay, so what is a wearing off phenomenon? Another thing important. Wearing off phenomenon is when the medication is not going to make effect. It's not having effect, it's not effect as before, okay? So in the MAO inhibitors, don't take it tyramine. The tyramine are in cheese, wine, beer. So you have tyramine. Tyramine is going to produce hypertension in selegiline MAO inhibitors. Dopamine agonist, the apokin, that is the second line. So MAO, then dopamine. Then you're going to do the carbidopa, levodopa. Oh, this one. You need to decrease the intake of supplements of vitamin B6. B6 vitamin. Right? So vitamin B6 has been shown to increase the peripheral breakdown of levodopa. So we don't want to have supplements of vitamin B6 if you are taking levodopa because the effectiveness is going to go down. COMT inhibitor, we have the entacapone. We have decoloration of the urine that is brownish orange. Very simple, because the patient is going to complain. There's something wrong with me. Okay. Anticholinergics, and then that is about the Parkinson. Any question? Cholinergics. Cholinergic, I'm afraid always to ask. Cholinergic is coming from the acetylcholine, yes or no? Okay, if you don't answer that,
Yes, it is.
It is, right? The
Yes.
acetylcholine, right? And the acetylcholine is going to have two main receptors. What are those? Muscarinic and the nicotinic.
Muscarinic and nicotinic.
Excellent. Which one we want to use? Basically, is the muscarinic. Okay. Cholinergic is going to use cholinergic receptors, right? Cholinergic receptors. What are those receptors? This one, nicotine and muscarinic. That is coming the word cholinergic agents. Cholinergic. Okay. Now, cholinergic, in order to remember, let's do very fast, is going to be everything wet, right? What wet? You're going to have urinary incontinence. What else? Increased defecation and increased salivation, correct?
Yes.
Cholinergic, giant cat, contraction. Contraction of the bladder produces evacuation. So more often, so people who cannot, they have a car accident in the spinal cord and they cannot contract the urinary bladder because some of the nerves are gone. So that is going to be benefit for this. Cholinergic agents. So they are going to be, for example, in the myasthenia gravis. What is myasthenia gravis? Myasthenia gravis. What is myasthenia gravis? Guys.
It's weakness.
Disease.
Destroy what?
The
Neuromuscular disease.
myelin. I don't know.
Acetylcholine? No.
It's a nicotinic
Nerve?
acid choline. It destroys the nicotinic acid choline. NMJ.
MJ.
NMJ. Sorry, that's not wrong.
Uh.
NMJ. NMJ. NMJ, neuromuscular junction. That is going to be destroyed by the myasthenia gravis. So if you, what is having the NMJ? This is the NMJ. NMJ. These are the receptors for acetylcholine. And that is what is going to release the giant cat, right? Acetylcholine, sodium, what else? Sodium, the T wave, calcium, etc. Right? So acetylcholine, the myasthenia gravis, what is happening? Look at this. Myasthenia gravis is going to be like that. So there is no receptors. It's going to be totally destroy the receptors for the acetylcholine. So what is supposed to have these patients? What they suffer these patients to do what?
Contract
Contract what?
their muscles.
Exactly. So they feel
Weak.
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 Can they brush? Can they brush their teeth?
No.
No, weak. They can eat. They can eat.
No.
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 They can I mean, change pajama or something? No, they can't.
No.
Right?
Mhm.
So what is the treatment? What is the treatment?
Cholinergic drugs.
Sorry?
Acetylcholine. Cholinergic drugs.
Exactly. Who said that? Okay. All right. Thank you. I don't recognize the voices. Well, okay.
Oh, it
ACA.
was Caitlin.
Okay. Cholinergic agent. So the acetylcholine itself as a drug is not that have much clinical application because it's actually short duration. There is other synthetic that are going to work for longer periods of time, more potent, are going to be, for example, the beta-nicole. Beta-nicole is discovered that is selectively stimulate the urinary bladder. So remember, we have the urinary retention when you cannot pee because you have injury in your back. So what you have is to give cholinergic agents to make the urinary bladder to contract, right? So if they contract, there is no urinary retention, there are going to be evacuation, okay? So that is the beta-nicole. I hope it's that clear, huh?
Yes.
Okay. Sjögren syndrome, no. Pilocarpine is actually very good for IUP, increase the oxygen, so it's going to decrease the intraocular pressure. Okay, it's being used for glaucoma. We have open glaucoma, closed glaucoma, etc. So definitely, yeah, pilocarpine is used for glaucoma. Okay, so here we have the few names I want you to go here. Forget about indirect acting, whatever. I'm not going to go that. But definitely what we want to know is this. Just a moment. We have the edrophonion, that is a cholinergic agent that is used for diagnosis of myasthenia gravis. Physostigmine is actually the anticholinergic. Is actually used for typically for overdose anticholinergic. So this is a cholinergic agent. Cholinergic agent. When we are going to talk about anticholinergics like the atropine, they are going to be the antidote. So the antidote for physostigmine, that is a cholinergic, is to the atropine, that is the anticholinergic. So when you have too much atropine effect, anticholinergic, you need to give the antidote that is the physostigmine. If the physostigmine is going to be too high, you're going to use as antidote the atropine. All right. So here we have the neostigmine, and that is what I want to focus on. The neostigmine, they need to be given 20 to 30 minutes before meals. Why is that? Why? Because the patient is going to recover some strength, and that is going to help himself to eat by himself, right? So that is the neostigmine. Okay, I'm not going to go that. That is the sarin gas. I'm not going to talk about that. Perfect. Any questions so far?
No.
To the third part of the review for midterm, and we are going to start talking about the antivirals, antifungals. All right, so here we have the mnemonic that we was talking in the past, just to remember. The RSV, the influenza virus, cytomegalovirus, herpes, HIV, hepatitis B, hepatitis C. All right, so for this, they have specific drugs that we are going to go bit by bit. So I'm going to just mention what is important. Everything is important, but what is more important, I cannot do the whole lecture. I'm doing how many? 20 hours of lecture in 2 hours. So it's a lot. So okay, so cytomegalovirus is a virus that is going to produce serious complication, right? We have the CMV retinitis that can be happening in the fetus if you're pregnant, or it can happen in the person who is having the cytomegalovirus. They produce retinitis, inflammation of the retina, and lead into blindness. So the herpes, we have type 1, type 2, type 1 labial, type 2 genitalia. Hepatitis B and C, we have the, we already know what is ictericia, jaundice, where is located most commonly the jaundice. HIV. Let's talk about antiviral drugs. Antiviral drugs are going to kill viral infected cells and healthy cells. So please be careful with this. Kill viral infected cells. So normal cells who contain inside some virus. So that is antiviral. And they can actually destroy normal cells without having any virus there. So that is where is coming the side effects of this antiviral. So 3 things that we need to remember: antivirals, similar as the antifungals, are going to be hepatotoxicity, nephrotoxicity, and rash, right? So they 3 common things for both antifungals and antivirals. So if somebody is asking you what is the side effect of antiviral, whatever antiviral, hepatotoxicity, nephrotoxicity, and photosensitivity or rash. Okay, what is the side effect of the voriconazole? Voriconazole, oh, okay. So hepatotoxicity, nephrotoxicity, and rash of photosensitivity. Okay, all right. In the long run, we are going to use, for example, sidobudin is the ACT that can produce this, is used for long periods of time. We have osteodystrophy, similar to osteoporosis, open eyes, open ears. Insulin resistance. Insulin resistance is diabetes mellitus type 1 or type 2?
2.
Excellent, type 2. Lipodystrophy is the degeneration of the connective tissue. So how to remember that? Oil. Probenecid is used for many medications in order to decrease the nephrotoxicity. It's a nephroprotector, kidney protector. Okay, ribavirin for RSV, respiratory syncytial viral infection. Mostly happen in kids less than 2 years old, so aerosol form is a very good route. We have the influenza virus, we have the amantadine, zanamivir, or oseltamivir, oseltamivir. Okay, so those are mivir. So those are for the influenza virus. Ganciclovir with bone marrow suppression, that is the bad guy, remember? Bone marrow suppression. Ganciclovir cytomegalovirus retinitis, we talk about that. And in general, again, we have liver problems, we have kidney problems. Acyclovir, none of these antivirals are going to cure a virus, never. What they are going to decrease is the duration of the disease. Don't share treatment when you're using acyclovir. Burning when you apply, so you need to apply very thin layer of acyclovir. We got that. The IV should be taken no less than 60 minutes. Can produce hypotension. Lamivudine is for hepatitis B. Lactic acid. The sidobudin is an antiretroviral in combination. Can be used for other drugs. We have that this sidobudin or ACT are going to need to be taken. It's a cornerstone of the HIV treatment. Cornerstone means that it's the principal, the main drug to treat HIV. Without this treatment, there is no treatment. Okay, so they can lead into bone marrow suppression. Who else have bone marrow suppression? The ganciclovir, the AZT, that is the sidobudin. Okay, so sidobudin prevent maternal transmission. Less than 0.1% are going to have placenta transmission to the fetus. Okay, other medications that we used to with is the didanosine. Didanosine can produce pancreatitis, and the stabudin can produce some peripheral neuropathy representing a gait, so you cannot walk properly, so limping, in other words. Antifungals, let's go directly to our topics. Here is, okay, let's start with the beginning. We have some amphotericin B, nystatin. So remember, the antifungals can be divided in systemic or superficial. Systemic can be called deep fungal infections. We have the amphotericin that is systemic. Nystatin is for superficial. Miconazole, ketoconazole, itraconazole, there's a mix of them. They can be for systemic or for superficial. We need to remember that fluconazole, always they like to ask that, single dose for vaginal yeast, voriconazole, arrhythmia, so you need to ask AKGs. All right, so, and is every azole, miconazole, ketoconazole, itraconazole, fluconazole can increase the effect of the anticoagulants. What anticoagulants we know? The warfarin and the heparin, correct?
Yes.
Again, antifungals. Oh, hepatotoxicity, nephrotoxicity, rash. That's all what I want you to remember. And that is trimming down what, actually they're not going to thrombocytopenia, leukopenia, pruritus, they're not. Okay, so that is, so antifungals give with food because they can reduce gastritis. So basically, most of the medications need to be given with food. Liver and renal function, oral hygiene, CBC. CBC is to see if there is blood count, because basically people who have systemic fungal infections is because that is not common. That is happening only in patients who are having immune suppression. If you have a patient who has many infections in 1 year, 3-4 infections in 1 year, or they have 2 different infections simultaneously, antifungal or bacterial and virus infections simultaneously, 1 or 2 or 3 of them, yeah, so you need to suspect in some immune problem. Okay. No sexual intercourse when you've taken your medication for STDs. Flagyl, for example, no, Flagyl is metronidazole. So this fluconazole, that is going to be for yeast. Okay. Antifungal in formal lozenges, those are like candies that are dissolving in the mouth bit by bit when you are washing, releasing the ingredient into the tongue, where is the Candida albicans. Amphotericin B. So what I want you to remember is this: pre-medication, because they can produce nausea, pain, a little bit of discomfort. So that is going to, and how soon you're going, how early you can give before giving the medication. You already know that if you're going to get PO, it's going to take about half an hour, right? Remember pathoanatomy, physiology of the stomach, half an hour to make effect. So you're going to give half an hour before, okay? Diphenamine and steroids prior infusion, that is because of the side effects. use infusion pump, no less than 1 hour, please, no less than 1 hour. They can produce phlebitis, thrombophlebitis, inflammation of the vein. So you need to be careful with that. But the main thing is just to give the medication in no less than 1 hour. So infusion, normal saline solution in no less than 150 ml per hour. Okay? Okay. We have different, the amphotericin B is for systemic. There is a new one. It's not a new one. It's like 15 years old already. It's lipid amphotericin B have less side effects. Okay, so please, huge here, huge. Hypokalemia. Hypokalemia. That's the way you can remember everything that we was talking. Voriconazole. What I want you to remember is the EKG can produce arrhythmias, visual disturbances, blurred vision, voriconazole. No, caspofungin is an aspergillosis. Aspergillosis is a fungus, right? Aspergillosis that actually is very difficult to treat. They can enter into the lungs, and your lungs, you know what? Your lungs become like cotton. How I know? Because I opened a guy who was dying with systemic infection of the fungal infection. Well, we didn't know, but at that time, then we know that it was HIV. But yeah, I opened the thorax. It was literally like a dark, brownish, gray cotton all over the lungs. So that is aspergillosis, one of the fungus that can produce this. Grisofulvin is for so the previous one we was talking about the deep fungal infections. One thing I want you to keep in mind, and please, if you don't remember, I want you to take note and look for this, is the histoplasmosis. Histoplasmosis. That is produced by the Histoplasma capsulatum, that is on the Cape disease. Cape disease. So, but we don't live in caves. Yeah, well, just a moment. So we have the central part of the United States. I know that area. Even myself, because I love caves. Is Ohio, a part of Indiana, Tennessee, Kentucky. So those areas where they have a lot of caves, and there is a lot. And what happened? Because the cave itself, no, because there are some bats that live there. The bats, they poo, and the bats they sleep with upside down, right? So they poo and poop. They will go to the floor. But it's not only one poo. There is thousands of them, and not only one day, for many years. So you have like a big cushion of like a mattress of poo-poo. And this poo-poo of the bat is where is living this histoplasmosis. Histoplasmosis, or any fungus, they love to live in acid environment. Acid environment. We already talked in the past that bacteria do not like acid. Bacteria, they hate acid, but the fungus, they love acid. So when the day and night, cold and hot, the temperature go up, start to evaporate, like fumes coming out, and these fumes start the spores of the histoplasmosis. You get into the cave, and you inhale those things, and you start to develop the histoplasmosis, similar signs and symptoms as tuberculosis. We have 50 cases every year in the United States in that area. And that is question for NCLEX. I saw the question for NCLEX. So, all right, so that's what I mentioned. Grisofulvin is the grandpapa, grandmama of all the antifungals. Is for superficial mycosis. Name that you need to remember is the onychomycosis. Onychomycosis. See, I didn't even mention Lamisil that is over the counter. what I want you to remember is this: the names that are going to ask you probably what is onychomycosis, what is the treatment for onychomycosis. You need to know what is onychomycosis. Onycho means what? Nails. Mycosis is mycosis. So you know superficial mycosis. So here the ointments or creams that you use for superficial mycosis, we have nephropathy, hepatotoxicity, and photosensitivity. Nephropathy is not very likely, right? Because it's superficial. It's absorbed by the skin, right? Liver, neither. But photosensitivity, yes. Photosensitivity. So this is topical. But if you receive parenteral or enteral, the systemic, you most likely you expect hepatotoxicity, nephrotoxicity, and less photosensitivity. Okay? Anti-malaria drugs. We have the chloroquine. Okay, so here, okay, so this is something. The chloroquine. Okay, so the chloroquine, I was surprised that chloroquine was used for coronavirus. I was surprised, really surprised, because chloroquine that I know it doesn't have antiviral effect. There was empiricals who was trying to do that. Chloroquine, probably the effect that was having in this process is the chloroquine, besides that is being is used to treat for malaria. Besides, they are going to treat arrhythmias. They can be used for arrhythmias. They are going to be used as anti-inflammatory. As anti-inflammatory, very, very inflammatory. So, for example, when you have rheumatoid arthritis, you start with aspirin. Then you start with NSAIDs. Then if that is not working, you start to do corticoids. If the corticoids are not working, are going to use antimalarial. If that doesn't work, methotrexate. So different levels. So, and this is one of the effects of the chloroquine, anti-inflammatory. Okay, but here in for exam, for NCLEX, they like to ask you what is the chloroquine for malaria. Malaria. I explained already about malaria, and here we have two medications. The chloroquine that is going to attack the protozoa. So remember, mosquito transmit the disease. Mosquito. But the Plasmodium vivax is the cause of the disease. Okay? We got that? The chloroquine side effects are going to be, it's called what? Cinchonism. Cinchonism. That is the toxicity of the chloroquine. Cinchonism. Cinchonism is the toxicity levels of chloroquine. And what are these? Cinchonism is going to produce tinnitus. Tinnitus, the ringing of the ear. This tinnitus is reversible. So once you stop the medication, you're going to just return to normal. Cinchonism, or Kinsonism. This is going to be working inside the red blood cell. So that's why it's called that. It's going to act in the erythrocytic phase, where it's going to be inside the red blood cell. Another side effect that I want you to remember very well is LES. LES is lupus, SLE, sorry, it's SLE. SLE is systemic lupus erythematosus. Erythematosus. So the erythema, redness, especially on the cheeks, forehead, nose. Why? Because produce photosensitivity. so signs and symptoms of lupus. But it's not given, it's not going to make you have lupus. I said signs and symptoms similar to lupus. The exoerythrocytic that is outside of the red blood cell are going to be used the primaquine. Primaquine that is due in the we are not going to use in pregnancy. Why? Because they can produce, unfortunately, I saw some cases of very unfortunately blindness. Okay, so remember you're going to take especially the chloroquine 2 weeks before and 4 weeks after your trip to areas of endemia. Means the cases of malaria are normal there. Okay. Antiemetics, they vanished from this curriculum, but still they asking, well, anyhow, parenteral diarrhea. I'm not going to talk about that. In dermatological drugs, we are going to see, all right. So let's see. Mupirocin, the Bactroban. Is topically for Staphylococcus, Streptococcus impetigo. What is impetigo? Impetigo is the infection of the Staphylococcus or the Streptococcus. Impetigo. Okay? So the Staphylococcus, we have the MRSA. MRSA is the methicillin resistant Staphylococcus aureus. Methicillin is a very potent medicine, antibiotic that was discovered in the early 50s. And the first resistance to this antibiotic was in the early 60s. So that's why since then it's called MRSA. So what is the treatment? The mupirocin. Silver diazine, the sulfur. Sulfur diazine, the sulfur, sulfur, right? Sulfur. Just to remember, sulfur. This sulfur, if you are allergic to sulfas is an antibiotic. Another one who has sulfur in his component is the diuretics, especially the furosemide, thiazide, etc. Okay, sulfas and diuretics. So if you are allergic to these, you can have allergic. If you are allergic to sulfas, you can be allergic to this, allergic to that. Diuretic. So we need to apply a very thin layer. Why? Because all these medications can lead into burning sensation. Okay. Sulfamylone, the same thing. I'm going to apply in very thin layer. Sulfamylone is for burns. So the previous one, silbediazine, is for burns. Burns. If you apply too thick, you're going to have, in addition, a burning sensation. So, but the medication for this is the silver sulfadiazine. That is actually bacteriostatic. So what that means, bacteriostatic with bactericide. Bactericide means that kill the bacteria, But bacteriostatic stop the multiplication. They don't kill, they stop the multiplication. So they will die by aging. They die old, the bacteria, unable to multiply. In other words, there is no next generation. Sulfamylone, the same thing. Sulfa, remember that. For this, let's talk about the isotretinoin, or that is the vitamin A. Is the derivative from vitamin A. Oh, there you are, vitamin A. Isotretinoin, we have the tretinoin, another name is the same, okay? It's derivative of the vitamin A. So the problem with this is, well, that's not the problem. This is a very good treatment for acne. Very good treatment for acne. All right, so open eyes, open ears. Okay, here we have the isotretinoin is used in the iPledge program. When these girls who are going to use this, they need to take two exams, two methods of contraception, two pregnancy tests in order to receive the treatment. The problem with this are going to be crusted skin. So the skin is going to be like a crust, a redness, dryness of the skin. Okay, open eyes, open ears. I told you here, open eyes, open ears. And please be careful with depression, suicidal ideas. When you have suicidal ideas, the patient are going to be, they're going to isolate himself. Okay? The patient cannot sleep. So you can go into the room and say, how do you know the patient is depressed? Oh, excuse me, patient, are you depressed? Of course not. You cannot ask that like that, right? So the indirect way and a smart way to ask that is, how do you sleep yesterday? If the patient said, oh, excellent, no problem. If the patient said, I couldn't sleep, it's because that patient is in anxiety. It depends the time of anxiety, they can lead into depression. Okay, all right. Okay, all right, so we talk about that. Lindane for the pediculosis. They need to use a shampoo plus the comb. The teeth of the comb are very tight to each other, very tight. So some people, they say, oh, you give me Lindane, it's not working. Yeah, of course it's not working. Shampoo is not enough. You need to use the comb at the same time. Oh, not at the same time, but as part of the treatment. Sunscreens, you need to give it 30 minutes before, 30 to 45 minutes before the exposure to the sun. And when you go to the have a swimming, after swimming, you need to apply again. Okay, you need to apply immediately after you dry your skin and put cream there. Okay, so it's the best way to protect. So the main mistake here is that you take 45 very good cover, but then when you go to swim, you come back and you don't do anything. That is the moment where you need to apply again the sunscreen. Okay, so that is our class number 3. Okay, so we have 2 hours already of webinar. So I'm going to stop the webinar here. I'm going to have 5 minutes break, and then we can do the last part. How many we are here? Let's see. 18. So 2 give up. No, I mean they left. Give up. Okay, Altia.
They gave up, Dr. G.
Oh yeah, sorry. Just
I think, well, some of us already had our lecture. We just ended at 10, so it's exhausting for a lot of us, and we are tired.
yeah,
So
I know.
maybe that could be their reason. I don't think they gave up. I just think that since we already had class from 5 to 10
Calm down.
p.m.
It was just a joke. We have class at 6 a.m. as well.
Oh, I'm not being argumentative. I'm sorry. Don't give me attitude for that.
Okay,
She's
okay.
not.
Okay, all right. So I was joking. I know nobody's giving up. I'm totally the opposite. I'm not asking anybody. I encourage everybody to do it. Everybody's tired. Me too. I'm tired, very tired too. What time is it? 12:30.
I'm wide awake, Dr. G.
You're very awake?
I'm
Excellent.
wide awake.
Okay, so I
We
promise
don't
I'm going
sleep. We don't sleep around here anymore.
yeah. Okay. Oh, but you just came from class, right? Miss Ova?
Yeah.
Oh, Ova left?
Oh, no, I'm still here.
Okay. Oh, you are with
No, she's still here.
Victoria.
Oh,
Victoria?
no.
Correct.
Victoria's
No, we're not.
here. Lakshman's here. So is Oba.
I'm sorry, what was that?
He was asking if you just got off class.
Oh, yeah, I got off class. I'm at work right now.
Oh, okay. Okay. All right, so let's finish our review. We are going to just close this lecture and let's go to the acid controlling drugs. Yeah, we are going to have many multiple answers. Okay, and yeah, and we have 93 questions. Okay. Okay. All right, so let's record it. Okay. Let's start. All right, so let's talk about the acid control drugs, and I'm going to go straight to the point. We are going to do the classification that you must remember. All right, so please, I want you to be very careful of this. Antacids. Okay, antacids are not anti-H2. Okay, so some questions are going to mix the definitions. Antacids are what? Neutralizers, like Alka-Seltzer, like, right? Like, what else? I don't know. What else is the Malox, the aluminum, magnesium. Okay, so, and don't be confused and don't be, tricked, because when you're talking about anti-H2, those are not anti-acids. They are going, so anti-acids is, the other name is neutralizers. Okay, the anti-H2 and the PPI, what they're doing is to decrease the production of gastric acid. They are not neutralizing. They are going to decrease the gastric acid. Then we have the prostaglandins that are going to increase the thickening of the mucus of the stomach. And then we have the other one that is like a ring, is a coating agent, is a sucralfate that is going to actually give an extra cover of the mucus to protect against gastric acid. Then we have the prokinetic. The prokinetic that we was talking in the previous is the metoclopramide. Okay. Oh, what's funny? Okay. The prokinetic. Prokinetic is the metoclopramide. What it's going to do is to make all the empty the stomach faster. So if you have less time of food in the stomach, that is going to produce less gastric acid. Okay, antacids, you need to get familiar. Aluminum, what is the side effect of aluminum? Everybody, please.
Constipation.
Constipation, right? Magnesium is going to be diarrhea. Calcium carbonate, kidney stones. Sodium bicarbonate,
Alkalosis.
metabolic alkalosis. Excellent. Okay. Anti-H2, that is diminish the production of gastric acid. We have cimetidine, ranitidine, famotidine. The cimetidine, you need to be careful because they can lead into gynecomastia. Another side effect that you need to remember for this anti-H2 is the drowsiness. I don't know if that's correct. Spell it. Drowsiness. Drowsy. Okay, sleepy. So because they are similar as the anti-H1, right? Anti-H1 are in the whole body. H2 are basically in the GI tract, stomach. So because they are caseins, they can produce drowsiness. Okay. All right. Smoke is going to decrease the absorption of anti-H2. So you need to decrease all what is going to trigger out an increase of gastric acid. What is that? Coffee, for example. What else? Chocolate. What else? Spices.
Alcohol.
Excellent. Alcohol. Very good. Hot drinks. Spices. What else? Smoking. Okay. Okay, so cimetidine produce gynecomastia. We already talked about gynecomastia in the previous in the class. PPI. PPI, please, I need to change this. This is not a protein. For some mistake, it was changed and then start to repeat the same thing. It's a proton. Proton pump is going to be PPI, proton pump inhibitor. Proton pump inhibitor. Proton, what is a proton? Proton is an hydrogen. This is a proton, yes or no? Yes. This is hydrogen. We have one proton and one electron. This is hydrogen. But hydrogen loss in the first orbit, they can gain or lose. And in this case, they are going to lose the electron, and what is actually the hydrogen? Now it's a proton. So that is represented by H plus. So it's the same thing. So it's proton pump inhibit. So proton pump is going to, from the cells of the stomach, are going to pump out hydrogens into the lumen. So what we do is the proton pump inhibitor. They are going to inhibit the elimination or secretion of hydrogen. So the suffix for that is the prazole, omeprazole, lansoprazole, pantoprazole, or semiprazole. The most common is the Prilosec. You need to remember in the long run can lead into osteoporosis. Why? Because it's going to increase the elimination of calcium. And that can produce osteoporosis. Be careful with that. Okay, so increased elimination of calcium can lead into hypocalcemia. Okay, hypocalcemia. PPI increase the levels of warfarin. What else increase the levels of warfarin? Are the antifungals. Remember, antifungals can increase the levels of the azoles, especially can increase the levels of the action of the warfarin. Okay. All right, so let's finish this. Coating agents. Remember the arrow. These are the neutralizers. This is PPI, anti-H2. This is prostaglandin. Coating agent is this. This is a sucralfate. Sucralfate. They can produce coating agents, are going to produce constipation. Misoprostol, remember arrow like this, neutralizer, antacids, anti-H2, PPI. These are the prostaglandins, and this is the coating agent. Misoprostol is going to be contraindicated in pregnant because they can produce, it's used as an abortive in certain countries, abortive. So produce an intense contraction of the uterus. Okay, so the prokinetic. So remember antacids, neutralizers, PPI, anti-H2, prostaglandin. We have the prokinetic, or the coating agent, and then we have everything moving is the prokinetic. In this case, we have the Reglan, the metoclopramide that we mentioned in the previous hour. Okay. Simeticon for flatulence. Diarrhea, you're going to classify diarrhea in mild, moderate diarrhea. So we have the bismuth subsalicylate, that is the Pepto-Bismol. Pepto-Bismol for diarrhea. They can produce dark stools. Dark stools and blue gums. Okay. Okay. All right. So moderate diarrhea or severe diarrhea, we are going to use the Lomotil, that is the phenoxylate, and atropine. Atropine is an anticholinergic. Atropine is an anticholinergic. And the phenoxylate is derived from the opium. It's not addictive. It's not cause dependence. Okay. So this has antidiarrheal, bismuth subsalicylate, active charcoal, antilipemic. So focus here in the bismuth subsalicylate. Antimotili T is the anticholinergic, is the Lomotil, right? Cholinergic, everything wet, anticholinergic, everything dry. So what it's doing is decrease the peristalsis of the intestine. So that's why that is going to control the diarrhea. Opioids can decrease the same thing, decrease the peristalsis of the intestines, and that is kind of a side effect, but is useful in this case for anti-diarrhea. Belladonna alkaloids, that is anticholinergic, that is belladonna is a plant that is taking this drug. Okay. Remember, when you have anticholinergic, everything is dry. Dry mouth, urinary retention, constipation, blur vision, okay, blurred vision, and that is because the eye is dry, but that is why. Probiotics is when actually patients are having for long periods of time some treatment with antibiotics that is going to sweep out all the bacteria, and to replenish that, because you have a risk to have C. diff. You want population, you want competition, you don't. So, and probiotics is a bacteria that is part of the flora that are going to start competing with other organisms and repopulate in a balanced environment. So means no population bigger than others. Okay, laxative, what we need to remember here is number one, the use for long-term bulk forming. Then I have the mineral oil, decreased absorption of the fat-soluble vitamins, FADEC. We have clean before procedure, the PG, no PG&E, no, it's PEG, the PEG. Another one I want to remember is this is the fastest laxative, magnesium citrate. So everything that has magnesium is fast. Okay, so this is immediate, but it's not really immediate. It's about 4 to 5 hours. The fastest is going to be the magnesium citrate that is going to produce the defecation in about 2 hours. 2 hours. Irritable bowel. Always they like to ask this one, the linaclotide. Your irritable bowel is mostly psychological, mostly more than is psychosomatic. In other words, means that depends your mood. If you are very stressed out all the time and you're nervous, you actually affect your GI system. In which way? That you want to go to the bathroom every time you have a problem or you are in stress. Okay?